Okay, so I'd like to thank the organisers for giving me the opportunity to speak here today. So as Irina said, I'm going to be talking about a statistical method for cardiovascular risk prediction. Just to acknowledge everyone who's been involved in this work, so this has been quite a long ongoing research project which we started back in 2013. So the people who've kind of had their hands on the code over the process, as it were, are a team led by Angela Wood over at the Cardiovascular Epidemiology Unit. So David Stevens has done a lot of the work with CPRD. Myself, Mike Sweeting from the University of Leicester, and Ellie Page, who's now at the Australian National University. So going on to talk about cardiovascular disease. So it is important to accurately predict a person's risk of cardiovascular disease, because that is used to make treatment decisions. So an intervention might be prescription of a lipid-lowering drug or some kind of a lifestyle management recommendation. So currently in practice, if you visit your GP at age around 70, he or she might predict your cardiovascular risk using the most recently observed measurement of various cardiovascular risk factors. And the ones I've mentioned on the left here are blood pressure, total cholesterol, HDL cholesterol, and smoking status. But in a person's GP records, typically there are a lot of past measurements of all of those cardiovascular risk factors. So the idea when we set out to do this research was, can we improve cardiovascular risk by using all of that information that's contained in a person's medical records? So the aims are twofold. So as I said, the first aim is to improve cardiovascular risk prediction by harnessing all that medical history. The second aim that has developed as we've gone along is to develop a more targeted approach to cardiovascular screening, and in a two-pronged way. So first, to target higher risk individuals, so to target screening to those who are most in need of it, and also more recently to look at the scheduling of cardiovascular screening. So when to recommend that someone has their next cardiovascular risk assessment. So how would you go about using someone's medical history in a risk prediction model? So this is the trace of someone's blood pressure measurements. So what you might do, what's currently done in practice is to take their last observed measurement and use that in your risk prediction model. An alternative is to use the average of all their past blood pressure measurements. So if there's no trend in the data, then taking that average reduces the measurement error in your estimated current blood pressure. An alternative is to use a statistical model, like a mixed effects model, to fit individual random intercepts and slopes that enable you to predict from the model your current value of blood pressure. So when we're fitting a prediction model, we want to be able to assess how well that model's doing. And there are various measures that are typically used. So one is a measure of discrimination called the C-index. So this is the proportion of pairs of individuals whose order of risk prediction agrees with their observed order of events. So essentially, if you pick a pair of people, what's the probability that my risk prediction model is ordering their risk correctly? There are other measures, such as the Breyer score, which is the mean squared error of prediction. So all the results I'm going to present today are going to be results for C indices. That's not because I'm advocating the C-index as the only measure of measuring predictive accuracy, but just because the Breyer score gives us pretty similar results. So to avoid repetition, I'm just going to talk about C indices. And then typically when we assess our models, as some of the previous speakers have mentioned, in order to avoid an overestimation of how well our model is doing, we do some kind of split into a training set on which we fit the model and a test set on which we assess the model. So I'm going to move on now from talking about risk prediction as a static event to dynamic risk prediction. So dynamic risk prediction is when you want to monitor someone's risk over time. So suppose I start off at some time origin with some exposure measurement, and I want to estimate an L-year risk prediction. But then time moves on. So now this person has reached what I call TPRED. They've got another measurement of their exposure, and I also have the information that they haven't had the event up until TPRED. And I want to update my risk prediction in the light of that new information. And moving forward, again, time's moved on, I've got new measurements, I know they haven't had the event yet. What's my new risk prediction? So one method to do this is that's been proposed is something called landmarking. And landmarking, I see it as the method that kind of does what it says on the tin. So landmarking kind of follows landmarking kind of predicts risk in the way that it would be predicted in practice. So what do I mean by that? So if I wanted to predict my risk at baseline, I fit a survival model from baseline, and I use that to predict my L-year risk. Moving forward, so to predict my risk at time TPRED, I use a model, possibly, for my past repeated measurements to estimate what their current value is. And then I fit another survival model to people, only people who are still at risk at TPRED, moving forward into the future up to L years, and I censor it at my time horizon of L years. So I'm fitting a series of survival models, a model for each time at which I want to predict risk. So an alternative method is joint modeling. And joint modeling is different in that, excuse me, it involves a single statistical model. So I've just got a little bit of notation in order to describe the joint modeling. So I've got longitudinal covariate Z at baseline, survival covariates W. My longitudinal outcome is X, which is measured at time little t. And my survival event or censoring time is big T with event status delta. And so what the joint model does is it's also known as a shared parameter model. So we model the repeated measurements and the survival data simultaneously. And we do that by allowing the random effects. So in the repeated measurement model, I've got there a standard random intercept and slope model. B0 is my random intercept, B1 is my random slope. And these also enter into the survival submodel with association parameters alpha 0 and alpha 1. And those govern the strength of association between the longitudinal outcome and the survival outcome. So just a summary of how the two compare. So when I'm fitting the model, in landmarking I fit a series of survival models. I fit a mixed effects model to my past measurements and a survival model to my future measurements. In joint modeling, when I fit the model, I fit them a single model using all the data in one go. When I come to do risk prediction, so for landmarking, the risk prediction is in effect similar to the way you fit the model. So the risk prediction, you use your mixed effects model to estimate your current value at TPRED, and then you plug that into your survival model to get the risk estimate. So for the joint model, you have to do a little bit more work to get your risk estimate, because you have to take your single model and you have to estimate your survival, your risk from your survival model, conditional on the repeated measures that you've observed, and also conditional on having survived up until time TPRED. So comparing the two, so as I've said, they both condition on survival. In landmarking, that's done through sample selection, because we only fit the survival model to people who are at risk at time TPRED. In joint modeling, that's done through shared random effects. So in landmarking, because it's a two-stage model, although we can use a mixed effects model to reduce measurement error in our estimated exposure value, there's still some measurement error in there, and that's ignored in the model. Joint modelling incorporates all that uncertainty. Landmarking is sometimes criticised for being an inconsistent prediction model. There's nothing that says that the model that you fit at age 40 is consistent with a model that you fit at age 41. They're fitted to different sets of people. Joint modelling is a single comprehensive probability model. But one of the big advantages of landmarking is it's computationally simple. You just have to fit a mixed effects model and something like a Cox proportional hazards. Joint modelling is computationally very tricky because typically you have to integrate out the random effects in your likelihood using some kind of numerical methods. So going on to applying these methods to some data. So I said that I see this as kind of a research journey. So we started out small with the ARIC study, which is a cohort study of around 13,000. Then we moved on to a bigger data set, the Emerging Risk Factors Collaboration, or ERFC, which is individual participant data from, in total, around 38 studies with repeat measurements, so around 200,000 people. And then we ramped up the scale again, so what we're currently working on is data from the Clinical Practice Research Datalink, so GP records in the UK, so ultimately we'll have over 3 million people in that data set. Okay, so starting small with the ARIC study, as I said, around 13,000 individuals, over 2,000 events. And in this work, we modelled systolic blood pressure only. And so these are the results from the ARIC analysis. So these are the C-index results. So we've assessed a number of different models in a dynamic risk prediction setting, so at various different time points. So the models we've assessed are treating, so the circle here is treating the last observation carried forward as a time-varying covariate. Then we've got the diamond is landmarking with a last observation carried forward. Then the triangle, what I'm calling landmarking MM1, is using a mixed effects model with a random intercept only. And MM2 is random intercept and random slope. And then finally, the joint model is the blue. And what you can see, there's more separation between the models over time. So as time goes on, you have more repeated measurements. So you see a bigger difference. And what we find is that the landmarking model with the random intercepts and slopes and the joint model are tending to do best, although confidence intervals are quite wide here. So moving on now to the Emerging Risk Factors Collaboration. So as I said, we used 38 studies that have repeated measurements, so around 200,000 individuals and over 20,000 cardiovascular events. So in this case, we modelled 3 risk factors: systolic blood pressure, total cholesterol and HDL cholesterol, but in separate mixed effects models. So these are the results. So the joint model has already failed by this stage. We couldn't fit a joint model to this size data set. So we're comparing only a model that uses a cumulative average of past repeated measurements to a last observation carried forward. That's on the left. And on the right, we've got a mixed effects model compared to a last observation carried forward. And so the forest plots show all the individual study results. I know that's quite small, but we've got the overall results at the bottom. And what we find is we do find a modest improvement in the C-index from using the past repeated measurements. So that's consistent with the results from the ARIC study alone. So ramping up the data size another level. So this is now data from the Clinical Practice Research Datalink. So this is UK GP records data. It's linked to hospital data and also to national mortality data. So in total, we'll have over 3 million individuals, but all the results I'm presenting today are based on a subsample of 500,000 individuals which we've split into 2/3 derivation and 1/3 validation or testing data set. So here's an example of some data from that database. So this patient entered the cohort around age 52. They had quite a few measurements of all the 4 risk factors. So I'm now also looking at smoking status, repeat measurements of smoking status. And they died from a cardiovascular event around age 68. So a second patient, a younger patient, entered the cohort around age 30 and left the practice around age 45. So they've got a few blood pressure measurements, some cholesterol, but no HDL cholesterol. So these 2 examples illustrate the nature of this data set. So it's a dynamic cohort. People are entering and leaving the cohort at different ages. We've also got missing data for some individuals. So we've also used a landmarking approach in this case, and we've used age as the time scale because that's the natural way to deal with this more kind of dynamic cohort. So as in the standard landmarking approach, we fit, so we're using now a multivariate mixed effects model to the past repeated measurements. And then, so for someone to predict their risk at age 40, we then fit a survival model which we censor at age 50 in order to predict 10-year risk. And we do that again, so we've actually done this every year up to from between ages 40 and 85. So moving forward in time, so you can see we're fitting a lot of models here. So just some more details. I mentioned briefly that we used a multivariate mixed effects model, so just a few more details about that. So this model uses, for simplicity, random intercepts only. We haven't fitted the model with random slopes. But we allow for those to be, because it's a multivariate model, we can allow for those random intercepts to be correlated. So we allow our different risk factors to be correlated with each other. And by doing that, that means that we can predict someone's value for HDL cholesterol even if they have no HDL cholesterol measurements, through the correlations with the risk factors that we do observe, like blood pressure or smoking status. Okay, so here are some results. So this is first looking at the hazard ratios. So because we're fitting a different survival model at each landmark age, we have a different hazard ratio estimated at each landmark age. And what you can see is that as age increases, all of those hazard ratios are kind of trending towards the null in all risk factors. What that means is that we have less information in those risk factors to predict a cardiovascular event in older people. We find a similar trend with the C-index. So the overall C-index comparing across all ages is 0.769. So the red blobs here are the age-adjusted C-index. So these are the C-index from comparing pairs of people of the same age. So age is not a factor in the comparison of those two individuals. And what we find again is that the C-index declines as age increases. So by age 80 to 85, our C-index is not much bigger than 0.5. And what that means is that we're doing not much better than chance ordering of a pair of individuals. Just comparing some of the models again. So we find that the cumulative average does a little bit better than a last observation carried forward. Using mixed effects models does a little bit better than the cumulative average model here. And as an aside, we've also looked at what happens if, when you fit the mixed effects model, you don't just use the data from before the landmark age, but also data into the future. And we also find a small improvement from that use of future data. Okay, so I'm going to change tack a little bit here. So everything I've said up to now has been about building a risk prediction model that you can use to estimate risk in people, just using information from their GP records. So you don't necessarily even need them to come in for a risk assessment. I'm going to talk now more about the scheduling of cardiovascular screening. So that there's actually very little empirical work on this. So one of the first paper I found was this paper by Bell et al. So what they've done is they've taken two cohort studies, the Tokyo and the Framingham study, and they've used the visits in those studies to estimate cardiovascular risk at post-baseline 1 year, 2 years and 3 years from the Tokyo study, 8 years up to 19 years from the Framingham study. And what they've done is they've calculated the proportion of people who were initially at low or very low risk and who crossed the high risk threshold for intervention. And they conclude that the decision on when to rescreen people should be decided according to their baseline risk. But of course, they can't actually make any recommendation from these results as to when that risk assessment should take place, because they're restricted to the timings of the visits that were scheduled in those two studies. So very recently, last month, a paper was published in the Lancet Public Health looking at a 5-year versus a risk category specific screening intervals for cardiovascular disease. So they used a multi-state modelling approach, and they concluded that uniform 5-year screening intervals may lead to unnecessarily long delays in detection of high-risk individuals. And an editorial in the same journal called for a more informed, data-driven screening strategy. So these are some very preliminary results from some work I've been doing, again, with the Emerging Risk Factors collaboration. So I'm taking a similar approach to Bell et al. And trying to model how cardiovascular risk evolves over time. But because we've got our mixed effects models, we're not restricted by the scheduled visits in our studies. So what we've done is we've used the mixed effects models to predict how those cardiovascular risk factors evolve over time, and to use that to estimate how the risk evolves over time. And as you might expect, we find that the proportion of people in the very low group decreases over time, with more people moving to high risk. So this is ongoing work. So I'm just going to finish off by looking into the future and thinking about, as a statistician, what I would like to know. What more would I like to know in this context? And so I guess as a statistician, what I tend to do is think very carefully about the models that I'm fitting to the data. So the first thing is to go back to joint modelling. So with the increases in computational efficiency, I think we're not far off from being able to fit joint models to much larger data sets. So if we can do that, the question that then arises is, does that actually help? Does joint modelling deliver any improvement in cardiovascular risk prediction over something like landmarking? Also, looking at the longitudinal trajectories, are there other aspects of the longitudinal trajectories which might help us to predict cardiovascular risk? So one particular interest of mine is blood pressure variability. So you can see that the red person here has very variable blood pressure measurements. The blue person is much more even in their measurements. And what's been found is that the more variable your blood pressure, the greater your risk of cardiovascular disease. So can this help to improve prediction models by using something like blood pressure variability? Also, thinking more carefully about how this data has been collected. So we're using GP records data, so this is routinely collected data. It's not being collected according to some pre-specified study schedule. So for each measurement in the data set, there's probably a reason that that measurement is there in the first place, and possibly related to some underlying health conditions. So can we model that process of the measurements actually being taken? And again, does that help us with cardiovascular risk prediction? So I'm just going to finish off with a quick summary. So I've talked about a statistical approach to building a cardiovascular risk prediction tool using data from electronic health records. So we use landmarking for dynamic risk prediction and mixed effects models for repeated measurements of risk factors. So extensions to these models could involve modelling the longitudinal trajectories more flexibly, accounting for informative observation of repeated measurements, or joint modelling. And other future work more on the applied side will be considering other disease outcomes, possibly multiple disease outcomes at the same time, and also looking at cost effectiveness or public health modelling. So do these improved prediction models, what difference do they make if they were actually to be used in practice? And I'll leave you with some wider acknowledgements of everyone who's been involved in this work. Thank you.